I hope everyone was able to grab a handout and one of the copies of the categories of reportable new information, so you can use it as a reference point for today. My name is Julie Doherty. I am the Director of Regulatory Compliance in the Human Research Protections Office here at the University of Maryland, Baltimore. And today our topic for HRPO Grand Rounds is going to be on reportable new information and what needs to be reported to the IRB. I want to make this presentation somewhat interactive. I have some examples throughout the presentation in terms of the different categories. If people have questions, please interject. And I'll also have time at the end for additional questions. So when we talk about new information, reportable new information, what is it? That's one of the most important things I think to understand. So the information that needs to be reported to the IRB, it's any new information that has not previously been known about the research study or was not previously reviewed by the IRB. So that's a pretty simple definition. In terms of what needs to be reported, from an institutional perspective, the institution is obligated to report certain things to our federal oversight agencies. Therefore, there are certain things that investigators need to report to the IRB. One of them is what we define as, or the term, unanticipated problem involving risk to research subjects or others. You'll hear that term a lot. What is an unanticipated problem? That is any information that is unanticipated, which means it's not in the IRB-approved protocol, consent form, investigational brochure, or any document that's been submitted to the IRB. It's any event that is related to the research as determined by the principal investigator. And it indicates that subjects or others are at increased risk of harm. And when we talk about others are research personnel, could even be family members. Something happens during the course of a study. So it's not just what might happen to a research participant, but it's research subjects or others. And we'll have some additional examples of that. So new information that falls into these categories, which we will describe in a minute, must be submitted to the IRB within 5 business days. Now, it's within 5 business days of the investigator or the study team becoming aware of an event. So if something happened 4 months ago and the investigator just found out about it today, then you are still within the time frame to report to the IRB. Something also to be aware of is that information can fall into more than one category. So the categories that we have, I believe there's 13 of them, you can actually choose more than one category for an event to fall into. Some definitions. These definitions are on our website. These are definitions that the IRB uses to determine when they're reviewing information that comes into the IRB. We'll be referring back to these. So there's noncompliance, serious noncompliance, and continuing noncompliance. Those are institutional definitions. They are not federally defined, but these are the definitions that this institution goes by. So noncompliance is failure to follow the regulations or the requirements or determinations of the IRB. Serious noncompliance is noncompliance that adversely affects the rights or welfare of a participant. And continuing noncompliance is a pattern of noncompliance that indicates that a deficiency is likely to result in further noncompliance or a circumstance in which an investigator fails to cooperate with investigating or correcting noncompliance, which we have had instances of that, where investigators are not willing to cooperate with remediation plans that have been directed by the IRB. So in terms of the reportable categories, this is in the handout, and then I have some examples. This is the type of presentation. We could spend 4 hours talking about reportable new information. We could have an example under every single one of these categories. but I'm going to spare you that, and I'm just going to give you some examples, and then if you have questions, please ask. So the first category we have listed here is information that indicates a new or increased risk. So again, new or increased risk means it's not in the IRB approved protocol, it's not in the consent form, it's not in the investigator brochure. The IRB hasn't seen it. Here's an example. And all the examples I'm giving are actual examples of things that have come into the IRB. So here's an added new risk for an oncology drug. And these were not in the currently IRB approved protocol. So added new risks, face edema, generalized edema, localized edema, periorbital edema. And then another one that has an increased risk of attribution. So the attribution changed to likely from less likely. Neutrophil count became decreased. The reason that these are so important to be reported to the IRB is these are new events and new occurrences and new risks that research subjects need to be made aware of, because this may determine whether a research participant continues to want to participate in a research study. Reportable category number 2, any harm experienced by a participant or other individual which in the opinion of the local investigator is unexpected and at least probably related to the research. So what do we mean by unexpected? So its severity and specificity are inconsistent with what is currently in the IRB approved protocol or in the investigator's brochure. Probably related, again in the opinion of the investigator, means that the research procedures were more likely than to be what caused the harm to the research participant. Category number 3, noncompliance. So category 3 and category 4, noncompliance and then failure to follow the protocol, can be used many times interchangeably. So number 3, noncompliance with the federal regulations or with the requirements or determinations of the IRB. Here are some examples. So protocol expiration. We all know that IRB approves a protocol for 1 year, 365 days. If your protocol expires, there should be no research-related activities, no enrollment. So if it expires and you are submitting it late to the IRB for continuing review, that's noncompliance with the federal regulations. Non-adherence with the IRB approved protocol. If you are doing procedures that are outside of the defined and approved protocol, and you are reporting it as if you're doing quality assurance activities, monitoring activities, or you have an outside monitor who's come to the facility, there may be something that is noted and you have to report it as noncompliance. Or if you note it yourself during study visits. One which we see more than we really should is over-enrollment. When an investigator submits a protocol, they state how many participants that they believe they're going to be able to screen and how many they're going to be able to enroll. And this goes, one thing that study teams and investigators need to keep in mind is you have to pay attention to the number you were approved to enroll. That goes for if it's a greater than minimal risk study and it's a drug or device study, all the way down through a study that might be minimal risk and it's a chart review. You have to pay attention to the number that the IRB approved. When we have continuing review reports that get submitted and it's noted that there's been over-enrollment, our staff will query the investigator and request that they put in an R&I, reportable new information. Why the over-enrollment occurred, what you're going to do to prevent future over-enrollment. And one of the biggest things to consider in terms of over-enrollment is the IRB will then consider whether or not the data can be used. So if an investigator has done a chart review and has looked at 1,000 charts instead of 100 charts, there's a good possibility that those additional 900 charts, you will not be allowed to use the data. So it's extremely important. The other thing is that you could be exposing participants to risk by going over the enrollment number, because statistical power and what was approved in the protocol is determined by the number of participants that are going to be enrolled. So it's extremely important to pay attention to that. It happens much more frequently than it should. Category number 4, failure to follow the protocol due to the action or inaction of the investigator or research staff. Again, non-adherence with the IRB approved protocol. A lot of times, number 3, number 4 come in, and one of the most important things for the investigator to include with this type of report is how they're going to prevent it from occurring in the future. So your protocol expired, or you didn't adhere to all the activities that were supposed to be conducted during a study visit. How are you going to prevent it from happening in the future? Big component of this is education and training for the research staff and making sure they understand what are the activities that have been approved by the IRB to be conducted in a study. Breach of confidentiality. So a breach of confidentiality, again, this is a real-life example. Breach of confidentiality could be either an unanticipated problem involving risk to research subjects or others. We hear about it daily in the news. We've probably all been exposed to a breach of confidentiality. Your information gets stolen from, Home Depot or something like that. You've lost the information. That would be considered an unanticipated problem. No one thought that that could happen. This example here is where someone decided it would be a good idea to email a database with protected health information to the study team. Not a good idea. This was actually determined to be serious noncompliance because it violated the rights of the research participants who were in the study. What we see here is this was what was included when the investigator submitted it to the IRB. So a comprehensive submission, including what was the management plan. So for unanticipated problems involving risk to subjects or others, how is the investigator going to manage what happened? How are they going to manage it in the short term? How are they going to manage it in the long term? So in this case, after it was noted that it was emailed to everyone, the investigator told the study team, delete it from your email. That's a good thing. And then re-education and training on what can and cannot be emailed. And then an internal SOP for how they were going to proceed on how data was going to be distributed amongst the study team members. The other thing to keep in mind is part of the management plan, whether it's an unanticipated problem or if it's serious or continuing noncompliance, is how and should participants be notified that this has occurred. So should these participants be notified that their protected health information has been emailed amongst the study team, unencrypted? This is something that the IRB will decide. The investigator may say, we'll notify the participants, or we may not notify the participants. But the IRB has the final say in the determination as to whether or not that will occur. And they have to look at the risk-benefit in terms of, is it going to cause more distress, more undue stress to participants to know that this activity may have occurred. Category number 6, so change taken to the protocol without prior IRB review to eliminate apparent immediate hazard to a research subject. So this isn't, let's get around this inclusion-exclusion criteria. I'll make the change to the protocol, and then I can enroll the participant. That's not what this means. Immediate apparent hazard to a subject. What that means is, say a participant's coming in for a study visit, and they show up and they complain that they're having chest pain. The investigator may make a change to the protocol, and they may say, you need to go see a cardiologist, you need to have a CAT scan, you need to have an MRI. Something additional is being done to eliminate an immediate apparent hazard to a subject. It could be that more blood has to be drawn, additional blood work has to be done, additional testing has to be done. That's being done to eliminate an immediate apparent hazard to a subject. This is the type of thing the IRB needs to know about. It might fall under an unanticipated problem. More likely than not, it would never be deemed to be serious noncompliance because the investigator is looking out for the best interests of the research participant, but it's something that needs to be documented in the research record. Incarceration of a subject in a study not approved to enroll prisoners. This is also something that gets reported pretty frequently to the IRB. What has to be included in the information that gets presented is that data. Is there any reason to collect data on the participant while they are considered a prisoner or while they are incarcerated? It depends on the type of study that's being done. If it's an investigational type drug, it might be necessary to do it. This is where the principal investigator needs to work with the IRB because there's additional approvals that have to be secured. Versus participant gets arrested, gets put in jail over the weekend, and then gets out of jail on Monday. Yes, they've been incarcerated. Yes, you need to tell the IRB, but no study data or study interventions took place over the weekend. You weren't collecting the data while they were considered to be a prisoner. We get a lot of phone calls about this one category. Is somebody on home detention considered to be a prisoner? In the eyes of OHRP, Federal Oversight Agency, the answer is yes. If somebody's out on parole or somebody's out waiting to go to trial, we make phone calls to our oversight agency to ask the questions, because we want to make sure that the rights, safety, and welfare of these participants are protected, because prisoners can be subjected to undue influence and or coercion, and we want to make sure that they are protected. Another category, complaint of a subject that cannot be resolved by the research team. All of you have probably gotten a phone call from a study participant. Where's my payment for participation? That's always a good one. Where's my gift card for such and such? And you work with the participant, you work with the billing department, you work with whatever entity you need to work with to resolve that. Sometimes you can't come to a conclusion. Sometimes study coordinators, even investigators, have called me and said, this research participant is not being reasonable. I've worked really hard. I really need some support from the IRB. Can you work with me to help resolve this complaint? We have done that. We also have gotten complaints directly from research participants. The investigator won't work with me. They won't listen to me, etc. Yes, and there's two sides to every story. So we work very closely with the research team. But if you can't resolve a complaint, the IRB and the office needs to know about it so we can assist where we can. Premature suspension or termination of research by the sponsor or the investigator. So the study is IRB approved, it's moving along, it's proceeding, and the sponsor prematurely suspends the study. Could be for any reason. Could be for a serious adverse event that occurred. Could be because of an unanticipated problem that occurred. That needs to be reported. Sponsor decides to terminate the study early. They were going to enroll 50 participants. Now they're only going to enroll 25. Could be for a good reason. It could be for increased risk, or it could be that maybe a study endpoint has been reached, or interim analysis showed that actually the drug was working better than they thought, faster than they thought. It still needs to be reported. Now, this is whether it's a sponsor, private sponsor, or investigator-initiated type study. Unanticipated adverse device effect. What might those be? A study is inserting a catheter for whatever reason, and the catheter breaks, and part of the catheter remains in the participant. That's an unanticipated adverse device effect. Or if a device introduces energy, or EKG machine, or something that's being used, or defibrillator, and there is an adverse device effect. Patient experiences a burn that they weren't supposed to, or some type of adverse effect related to a device that's being used in the study, needs to be reported to the IRB. Audit, inspection, or inquiry by a federal agency. 3 different things in that one sentence. So an audit. The investigator finds out that the sponsor is coming to do an audit. The monitor is going to be audited for your study. Those results need to be reported to the IRB. This is regardless of finding. Inspection. So your study is under the purview of the FDA, and the FDA has determined that they're going to come in and inspect your study. Usually how we find out about this is we'll get a call ahead of time. The study team will call and say, we just received notice from the FDA, they're coming to inspect us. Can you please assist us with that process? We've never undergone an FDA inspection before. We will send somebody, usually myself or someone else who is in compliance, to meet with the study team, talk about what happens during an FDA inspection, what you can expect to have happen, how the inspection will proceed, what the outcome could potentially be. Whatever the determination is from the inspection needs to be reported to the IRB. So if there was no findings, or if there were findings, if the investigator got a 483, or if there's any type of report, it needs to be submitted to the IRB. Or inquiry by a federal agency. That could mean Department of Defense is a federal agency. They could call an investigator and say, we have a complaint about your study. Participant called, sometimes participants call the sponsors. They have a complaint, so there's been an inquiry. Or a family member calls or something like that. So any type of inquiry by a federal agency. Sometimes these types of events require more than one round of reporting. It could be an initial report and then subsequent follow-up reports, depending on how long it takes to remediate and come up with a corrective action plan. Written reports of study monitors. Those of you that work with study monitors, within 5 days of getting your monitoring reports, you submit them to the IRB. Again, these include whatever actions you are taking to remediate whatever the findings were. If you're following up on queries, or if there's any other types of events that have occurred. If there's queries that involve other categories of reportable new information, such as unanticipated problems or anything that might fall under serious noncompliance, it can be reported here, and then the IRB will go through it and look at it and determine if any additional reporting needs to take place. Again, monitors. You have a question?
Yeah, so just like a routine monitoring visit that didn't have any findings really, or it was just minor data queries, you want that?
Mm-hmm. A lot of these get reviewed and they get acknowledged. Others require additional follow-up, additional remediation or corrective actions on the part of the investigator. The last category is for VA research. VA has other additional specific requirements in terms of reporting. Besides unanticipated problems involving risk to research subjects or others, there also is a category of an allegation of noncompliance. So there could be an audit report or an issue that comes to light, and there's an allegation that there is potential noncompliance. That gets reported to the IRB, and then the process is gone through, it's reviewed, and it could be that the outcome, the IRB determines that there is no noncompliance. So any questions about these categories? Yes?
In category 5, you gave the example about deviation from the protocol to decrease the risk to the subject. How does that relate to if you have a medical incident occurs that's not related to the study? You're working with patients in the intensive care unit. They have a medical issue that occurs. You deviate from the protocol to allow that issue to resolve, to be reported.
What you're saying is could be reported under number 6.
Yeah.
Change to the protocol taken without IRB approval to eliminate an apparent immediate hazard to a subject. So if you're rendering emergency care or emergency procedures or medical procedures, patients in a research study and something happens, and you're doing things that are outside the IRB approved protocol to eliminate an immediate apparent hazard to a subject, needs to be reported.
I guess that's not my example. I do the emergency procedures, but let's say somebody else did it outside my relationship in the study of this subject. I put the subject on hold while the medical issue is resolved. Do I need to report it if I was not the one, in your example, giving emergency care?
It needs to be reported by the principal investigator if that patient is a research participant. You may not be part of the research team, but if that...
And I am part of the research.
Oh, okay.
But the medical staff is who addressed the medical issue. Had nothing to do with the research study itself, but it later changed our ability to do and implement the protocol.
Yes, it should be reported, yes. Yeah, Kathy?
I think it was hard to hear what she said, but I think what she was saying was that, like, if your protocol time points are, 2 weeks, 6 weeks, 10 weeks, and 6 months, and because of a medical issue, somebody gets off their schedule and you put them on hold, you would not be following the protocol because you're not doing it at the time points. Is that correct? And that's reportable.
That's what I'm just asking. Yeah.
Yeah.
I mean, that would be another example.
Okay, so that is reportable.
Mm-hmm.
Okay, I have another question about that same category. So routine.
Failure to follow the protocol?
Yeah, failure to follow the protocol by an action or inaction of an investigator. So a protocol, let's say, has a certain amount of urine, blood collected on a certain time point. And all the blood samples weren't collected. Maybe an investigator forgot to draw a tube, and so one thing wouldn't be done. Is that reportable? So that's reportable. If a participant doesn't show up for a visit, that's not by an action or inaction, so that's not reportable.
Yeah, I mean, it's...
Deviations are some, like, I have
Right, and a lot of times...
deviations from protocols, lists of them sometimes.
Right, exactly. And we have some investigators who will submit them as, under a monitoring report, say if it came in as a monitoring report. We have other investigators who decide that every deviation needs to be reported separately, which in and of itself is a large volume. Right. We have other investigators who might submit them per patient. The thing that the investigator has to look at, and which the IRB looks at, is if you have, say, 50 data points for a study and 25 of the data points were never met. So you need to look at the reasons why. Is it something the investigator could control, snowstorm, something like that, or is it something that the investigator couldn't control, but does the protocol need to be modified? Are you ever going to meet the study endpoints, the investigator ever going to meet the study endpoints if you haven't collected the data that was approved by the IRB?
No, I completely hear what you're saying, but what you just said was some investigators decide to report it like this and some decide to report it like that. What is the expectation of the IRB? Previously, the previous policy was if it affected the study integrity, safety of participant, that's when you would report a deviation. So a simple deviation like not drawing a tube of blood for banking, you wouldn't report that to the IRB. Are we supposed to report that now? It technically is non-compliance with the protocol.
Right.
But doesn't seem to me like it would be raised to the level of importance to report as an R&I. That would be my judgment, but
and usually what I've seen happen is if it happens like 3 times and it happens on 3 different subjects, and the investigator then realizes, oh, something's going on, now I need to report it, and they might report it. All 3 participants are reported, at once. I think that's appropriate.
I mean, obviously, if you have a lot of things like that, it might be an investigator conducting sloppy research.
Right.
And it would affect the outcome and your analysis.
Exactly. And if you have multiple deviations, you need to look at why. Is it something you can control? Is it something you can't control? Do you need to modify the protocol so that you can collect the data that you want to collect? Are you trying to collect too much data? Somebody else had a question.
Does that include people that miss a visit because of their own accord? They're sick, or they cancel, or you can't get a hold of them, or they say, no, I don't want to do it. So if they refuse a 2-month visit.
No, action or inaction of the investigator. So participants that doesn't show up, I mean, you can't control that. But you're right, you're still not following the protocol. I mean, you would document that in your research record.
I have a question on the written monitoring reports.
Uh-huh.
So, I'm just a little confused in terms of how it needs to be reported. I mean, I've reported them, and then sometimes I've had them bounce back by saying, well, show the PI oversight. So then I have the PI review them and sign them as indication of his review. It's taken longer than 5 days. And then I get bounced back because it's taken longer than the 5 days. The monitoring reports are basically an assessment of reviewing the patient's records. And times when the monitors come in, they write a review of what blood was missing. So it can serve as like a protocol deviation, but it's also like a checklist to do for the next time. And a lot of times these reports are bounced back as to why this wasn't done. Well, it's not done because it's not urgent. It will be done by the time the next visit or the next monitoring visit. So is there any consistency on how we're supposed to report these in a timely fashion without having them bounce back with so many issues?
So the report after you receive it should be submitted within 5 business days. And there are many things within the monitoring report which will not have been addressed because you've just received it, and it could be you have until the next monitoring visit to finish up the queries, or you might have a week or something like that. I mean, it shouldn't be bounced back multiple times because sometimes the remediation process has not been complete. The important part is, what's happened in terms of you've gotten the report, it needs to be submitted within the 5 days, and then it could be the corrective actions written right in the monitoring report. You have, 2 weeks to respond to this report and submit whatever information needs to be submitted. But the back and forth, unless there's another reason, I would not expect that to happen. One of the reasons that we started looking at monitoring reports is after going out and doing a lot of auditing and monitoring, we were finding that there was a lot that investigators were not reporting to the IRB. So the noncompliance, even protocol deviations back when we referred to them as those, and failure to follow the protocol, none of that was being reported to the IRB. Nothing was being reported at continuing review. But there was a lot of information contained in the monitoring reports, which demonstrated that the protocol was not being adhered to, and a lot of study data was not being collected according to what was outlined in the protocol. So that's why that change was enacted. Any information or other information that doesn't fall into those categories is not required to be reported to the IRB. And it's interesting, several times, we'll get reports that get submitted, and right in the body of the report it says, this event is not related to the research. Well, you just answered your own question right there. Doesn't need to be reported to the IRB. Other times, the sponsor will say, this has to be reported to the IRB. We don't think it's related. It's most likely not related, but we want it submitted to the IRB. And we understand that. I mean, we're not going to get into a contest with the sponsor to say, yes, we won't accept this. You say, please, the sponsor wants this to be submitted. You can submit it. A lot of times, even if things don't meet the requirements for being reported, they'll be acknowledged. But that's why we want you to really be familiar with what the categories of reporting are, because you could be overburdening yourself and reporting things that don't need to be reported. Again, if you have questions, we get questions all the time. Can you assist us with, determining whether this needs to be reported? Yes?
I guess kind of in that vein, am I correct that if you have an SOP how to do some procedure, but it is not submitted, it's not part of your protocol. It says we're going to do, a treadmill test, and you put the wire on wrong or something that's in your SOP that's not submitted to the IRB, that's not then reportable, correct?
So it's not failure to follow when we talk about the protocol, it's the IRB approved protocol. But if you, in your IRB application, have talked about, oh, we're going to follow this procedure and we're going to do it this way, and then you put 15 people on a treadmill and 14 of them treadmills done wrong for whatever, you've just subjected 14 people to a procedure that you're not going to be able to, analyze the data. So you might be exposing participants to increased risk because you're going to have to put them back on the treadmill. You're going to have to change the protocol. You're going to have to potentially have the patients, do another treadmill that they didn't have to do before. Okay, so in terms of submitting them electronically. So within each IRB approved protocol, now you can't submit anything unless your protocol has been approved. We've actually had people who have asked, well, I have something to submit, and it's like, well, you can't because your protocol hasn't been approved. You can submit RNIs on currently approved protocols. You can submit an RNI if your continuing review is being done. You can submit an RNI if your modification is being done. You can submit an RNI if your protocol is closed. And we'll talk about why that would be important in a second. So you click on the button, create new information report. The investigator can do this. Study team members can do this. If you're submitting reportable new information and you're a study team member, I would work very closely with your investigator on what you're reporting. And if your investigator is not available, a co-investigator. We have had instances where things get reported and it's not all the information is there, all the facts may not be correct, so there needs to be the investigator or a co-investigator. So, and then categorization. What are you reporting to the IRB? So there's the 13 categories. And don't worry if you accidentally pick the wrong category and submit it to the IRB. Based on what the information you've presented, we can basically figure out what category it should be under. That doesn't pigeonhole you into any type of further documentation. So what are you reporting to the IRB? Again, check the category. You can pick more than one. Describe the problem. This is important. Succinctly describe what happened, what the problem is, the type and nature of the problem, and any additional information to help to describe the event. When did the problem or the unanticipated event occur? A full description of all the activities leading up to the problem, if you know if there were any activities that led up to the problem. Any interventions or actions taken in response. So if the patient had an adverse event, it was related to this drug, you stopped dispensing the medication to the participant. You called the participant and told them to stop taking the medication. What's, if any, temporal relationship to study activities? Is it study related? Is the event you're reporting related to the research? And very importantly, what's the current status of the participant? So you're reporting this event, it happened 5 days ago. What's the current status of the participant? This is extremely important. We're here to protect research participants, to ensure that their rights, safety, and welfare are protected. So the IRB needs to know what's the current status of the participant. Have they recovered? Are they still in the hospital? Did they get the medical care that they needed? When you became aware of this information. So if you became aware of this information 3 weeks ago and are now just reporting it to the IRB, you're going to get a query back from our office saying, why did it take so long to be reported? Or if the event occurred 3 months ago and now you're just reporting it, you would include in your description, the reason I'm just finding out about this now is because the patient was lost to follow-up for the past 3 months and now we just found this out. Did the participant sign a VA consent form? This is important because this triggers a reporting cascade that we follow in conjunction with our partners at the VA to ensure that their reporting requirements are met. Their reporting requirements are different. They have a much more rapid reporting process, so this is important for us to capture. And attaching any pertinent documents. Do you have MedWatch forms? Do you have documentation from the FDA, the sponsor, anything that can support the event? And there's an upload function, as you know, in the R&I. Does this information indicate a new or increased risk? People will pick category 1 and then answer this no. If you're answering this no, then it could be you don't need to be reporting this. New or increased risk means it's not in the protocol, the consent form, or any of the IRB-approved current documentation. Does the protocol require revision? If you answer yes, you can write here that you're going to be submitting a modification as soon as you get the new protocol or investigator's brochure from the sponsor. Or if you say no, you need to provide a justification as to why you're not going to PI is not going to modify the protocol. Does the consent require revision? If you have a new or increased risk, one or the other or both of these should be revised. Because if it's new risks, the participant needs to know about them, and they need to be reconsented. Again, report it within 5 business days. The reporting is applicable to any study, regardless of who the funder is. So it could be federally funded, it could be industry sponsored, it could be investigator initiated. These reporting requirements are the same. So what are the PI's responsibilities in relationship to ensuring that information is properly reported to the IRB? So the investigator needs to monitor their research activities, to look at any indication of new information. For those who do industry-sponsored studies, federally funded studies, that process is a little bit more defined, fine-tuned. Someone else is looking at the information that you're submitting, and they are distributing information to the study sites. So you have someone who's looking at this new information. Those doing investigator-initiated studies, you have to be very in tune to what's in the protocol you wrote, what's in the consent form, and what's in the documentation that you've submitted to the IRB. The PI needs to determine if the information falls into a reportable category. Again, if you're submitting the information and you're saying it falls into one of those categories, and then you say, is there a new or increased risk, there's not consistency within the information that you're submitting. And you may not need to be submitting the information. The PI needs to make a determination about the new or increased risk. And the PI needs to make a determination about whether the consent or the protocol needs to be modified. One of the other things the investigator must do is determine whether the current research participants need to be informed. Do previous research participants need to be informed, depending on what the risk was? And do future research participants need to be informed? So it's not just who's enrolled right now and who's currently active on the study, it's previous enrolled participants and future research participants. If it doesn't increase risk to research participants, the HRPO will acknowledge the submission. If it does increase, if the information does indicate that there's an increased risk, the IRB will review and determine any additional requirements. You may get queries back from the HRPO office when they're triaging these when they're coming in, or you may get queries from the IRB. In terms of IRB actions, these categories, these reports come in on a daily basis. A determination gets made whether what's being reported falls into the category of an unanticipated problem involving risk to research subjects or others. The determinations about serious and/or continuing noncompliance for events that occur to participants who sign a UMB consent form. That determination is made by Dr. Rosenthal, the IRB chair, Dr. Hirschon, or another vice chair prior to it going to an IRB meeting. For the VA, the fully convened IRB has to make the determination as to whether something is serious or serious and continuing noncompliance. Allegations of serious or continuing noncompliance related to the VA also get reviewed by the fully convened IRB. The fully convened IRB is looking to ensure that the rights, safety, and welfare of participants are being protected. So what is the management plan for an unanticipated problem? How are you managing the event? Are you rendering certain care to the participant? Are you modifying the protocol, re-education and training for the study team? In terms of corrective action plan is implemented for noncompliance, serious noncompliance, or continuing noncompliance. How is the investigator and study team going to prevent that from occurring again in the future? Again, the management plan and the corrective action plan are approved by the IRB. But they're proposed initially by the investigator. Questions?
Kind of a practical, pragmatic. If there's something you're not quite sure, should I submit this, should I submit this? Is it more convenient for the staff to get this typed into as an RNI and they write back and say you didn't need to do that, or to call them and ask?
I would call and ask, and it happens a lot. We get a lot of phone calls. I'm not sure if this needs to be reported. I think it's very appropriate for you, investigator, to call and say, should I report this or not? Where I get a little bit leery with that is if study team members call and say, should I report this or not? Well, I always say to the study team member, you need to discuss this with the investigator, particularly on FDA regulated studies. If obviously there's an MD working on the study or someone who has a clinical background, all these decisions need to be made in conjunction with the investigator. But we'll certainly take phone calls from anyone, but I always, and the staff will say, you need to discuss this with the investigator. Because there's a different, investigators looking at it through a different lens in terms of, clinical aspects, medical aspects, so that's what I think is really important. But yes, certainly call, absolutely. Because, it takes some effort to fill these out and submit them. Yes?
If we submitted an RNI and it's been set to meeting Is there a way to add some supplemental information to that RNI, or do we have to wait to after it's reviewed, or can we put a public comment in there?
Yes, you can put a public comment in,
Okay.
and you can add whatever documents you want to add in the public comment. The coordinator and the IRB administrative staff are always looking at, Cicero prior to the meetings. They'll see that additional documents have been uploaded. They'll look at them. They'll make sure that the IRB reviewer is directed to those. But yes, absolutely.
And if our plan of action is a modification to the consent form and protocols, do we have to wait to submit that until we hear the determination?
No.
And we can work on that and submit it in the meantime?
Yes.
Okay.
Yes.
Okay.
Now, the other thing that I said is you can submit RNIs on closed studies. And that does happen. We do have information that comes from sponsors that is pertinent to a study. There might be additional information, and that can be submitted. It can be submitted on a closed study. And again, it could be that the investigator will have to contact the participants who were in that study to tell them about these new risks, particularly if there's something that was found on long-term follow-up. And that might require submission of a new consent form. And there's obviously you can't submit a modification on a closed study. But if there's activities that have to take place, we will make sure, and we will work with the investigator to make sure that those activities take place. If you've closed your study in Cicero, and say 3 months later, you get a document from the study sponsor that says, here's some more information about the study, and the sponsors decided, well, we think we need to notify participants because we're seeing on long-term follow-up that participants are getting liver failure or renal failure or something like that, and we want to notify the participants. You can create an RNI, submit the information, and if there's a requirement to notify the participants, you could submit a patient letter that says, summarizes the event or the events and what has transpired, and here's the information that we want to provide to the study subjects.
If you can't re-consent?
You can provide the information to them. Since the study's closed, we don't have the ability to stamp a consent form. So it could be just a patient letter that the sponsor has generated, which includes additional, whatever the information is about the new risks. And if the IRB approves the RNI and approves the plan, then they approve the letter. But we have it happen. I won't say frequently, but we have had it happen. The other thing we've seen sometimes is under category, I think it's category number 1, something gets published in the literature. And it gets brought to the attention of the investigator or someone else. And it's not the sponsor, but it's something that got published. Maybe about a drug that's in a study. That's another way that, information gets brought forth to the IRB. And there's been multiple times where the sponsor proposes a management plan or corrective action plan, and the investigator says, I agree with what they want me to do, but I also want to do, X, Y, and Z. I want to do more. Or in some instances, they want to do less. And then in that case, it's just provide justification and rationale for why you're proceeding the way you want to proceed. Okay, thank you.